Our next speaker is Dr. Anwar Siddiq. He's a consultant nephrologist and an SSMC, Sheikh Aboud Medical City. He is also an associate professor at Khalifa University as well. Welcome, Dr. Anwar.
Thank you very much, Abdullah, for the nice introduction. And I'll try and keep this brief and hopefully relevant and interesting. Are you? Okay. Okay. Thank you. So my name is Siddiq Anwar. I currently work in Sheikh Shabood Medical City, which is run by my clinic. So this transplant talk is mostly geared to the internist, and hopefully you will have some take-home messages today. Can you hear me? Yep. Am I moving the slide or? Can you hear me? Yeah. Can I start? Yeah. So I have no financial disclosures, and other than the fact that I'm the cutest nephrologist in UAE. About me, I'm originally from India, South India. South India has had dealings with Arab world for more than 2,000 to 3,000 years. Coffee came to India 2,000 years ago, to my state first. I trained in London, but most of my transplant training was in the US. And when you want to learn something, you need to go under a master. And I was very fortunate that I trained under one of the doyens of transplant nephrology. And to learn something, which JAMA published this 100 years ago, you need to have an apprenticeship. And Dan Brennan, someone who works in transplant field, knows him. He revolutionized how we practice transplantation, and I was fortunate to train under him and still get trained under him. So I was brought to bring about transplant growth. Abu Dhabi is very generous. Sheikh Zayed Marhoom made ESRD care free in Abu Dhabi, but unfortunately, most patients were on dialysis. Saha, which had the biggest dialysis program, was not referring patients for transplantation. So me and my coordinator, Emily, and 3 more practicing nephrologists, Ayaz, Wasim, and Chandra. Now 90% of all transplant referrals come from SEHA. And why do we transplant people with end-stage renal disease? Because this is the only cardiovascular risk reduction we have. So if you have a dialysis patient, your risk of dying from cardiovascular events is very high. But if you transplant them, this is the only way to bring back life. And this is the reason why we transplant people. Who do we transplant? So we make a risk assessment. If your expected life expectancy is more than 2 years on dialysis, we transplant those folks, because transplantation will definitely prolong life in these patients. And why do we transplant people? Not just because they're not off dialysis, but if you live for more than 2 years, it's cheaper than dialysis, and you improve your quality of life. Medicare, only other country where dialysis has become an industry, spends 10% of its budget, $60 billion on dialysis care. But only 1.1% of the Medicare population is on dialysis. In my back of the envelope calculations, we spend, Abu Dhabi government spends 1.5 billion dirhams on dialysis alone. And we need to transplant more people. And the way we transplant is living donors or deceased donors. Living donation is, and deceased donation is less in UAE, and hopefully as a community we can encourage this. So these are some definition of what a deceased donor would be. Standard criteria is anyone with an age of less than 60. Extended criteria is where you have potentially underlying CKD. Deceased cardiac death is donor after cardiac death, and DBD is after brain death. Yep. CTC high-risk donor is those are people who have Hep B, Hep C, HIV, or at risk of developing or other donor-derived infections. Even if we transplant people from marginal kidneys, your life expectancy is much better than on dialysis. And this is how a kidney donor's nephrectomy scar looks like. Very few surgeons do the mini laparoscopy. Nadi Hakim in in Imperial is famous, but he's got small hands. But most people do the full laparoscopic or partial hand-assisted laparoscopic surgery. So what are the indications for kidney transplant? Anyone who has an irreversible progressive CKD with a GFR of less than 20. Unfortunately, despite fancy healthcare systems in Abu Dhabi, still people crash land on dialysis in ER. And if you have someone with progressive CKD, we should be encouraging them to go and see a nephrologist for them to be transplanted. And when we're doing pre-transplant screening, we are looking and seeing, are they at risk of developing any cancer within the next 2 years? Are they at risk of dying of ischemic heart disease or stroke disease immediately? Because essentially this is an elective operation. We are seeing if they are non-compliant, because suppose you're doing a living donor transplant and this patient doesn't take medications, we've lost a kidney there. And obviously if you have non-compliance, then we would not do that. So we also screening for heart, because 20% of the heart's output goes to the kidney, so we want to ensure the heart pumps effectively. So absolute contraindication is if you have an active cancer or active infection or active lupus. And if you're a drug abuser, again, we would not transplant those folks because of non-compliance and concordance issue. Marijuana use is an evolving subject. In the West now, there's a lot of debate going on if marijuana users can be transplanted. Positive T-cell class match is still an absolute contraindication. Relative contraindications are people with severe obesity or chronic liver disease or peripheral vascular disease, because the kidney is plugged, as you know, to the iliac arteries. So if you have uncontrolled renal bone disease, also we should not transplant them, because we give them steroids post-transplant. Hence, they are at risk of fracturing. I'll talk more about pair exchange in a bit. So there are major immunological barriers. Since Medawar talked about HLA MHC complex, nothing much has changed. We still follow the same legacy of the 6 antigen match to ensure that transplant goes well. Obviously, blood group incompatible transplant is possible, but not encouraged. So frequently you hear physicians talk about mismatch. Suppose the line 1 is the donor and line 2 is the recipient. You're trying to see how many antigens mismatch between the recipient and the donor, and that gives the concept of mismatch. Obviously, we know which blood groups can donate, so I don't have to insult the audience here. So talk about pair transplant. So when I was brought to head the kidney transplant program in Seha, I realized the reason why the program is not growing is we have a small donor pool. If you just think about yourself, if you end up on dialysis, how many people you think in your life, in your family, who could donate, who's healthy enough to donate? Hence, I've been advocating for this program, and the way it works is if you have 2 incompatible pairs, we would find a match among themselves in this pair. And this could be a powerful tool. We can get more people transplanted who are currently not being transplanted. And if you have a deceased donor or an altruistic donor which doesn't occur in the UAE yet, you can start a chain by getting more uncompatible. Just think it like a speed dating. You just find compatible pairs for each other, okay? So I helped facilitate the first one between India and UAE last year, worked closely with Al Roth, Mike Rees, and we did this between India and UAE last year. And obviously the one which happened recently is, I will talk about more about this when I give the talk next week in Cleveland. So transplant surgery is an elective surgery. You plug the artery in the vein to the iliac artery. This is how most traditionally we do. The main risk, obviously, is the ureter leak, because the ureter gets the blood supply from the donor artery and donor vessels. So the ischemia can occur. We recently published our data from SKMC transplant program in the American College of Surgeons. We have a good program. The caveat being, we only do mostly living donors. So unlike in the West, where they do a lot of DBD and DCD donors. How our body, just switching gears about medications, How our body recognizes self and non-self is one of the fascinating things Allah has evolved us. Um, we need a strong immune system to ensure that we survive in this environment. And we have to overcome this to ensure that transplant becomes successful. And there are many redundant mechanisms we have to target. And you know about all these medications. And this is a good transplant nephrologist is one who can orchestrate this without killing the patient with over-immunosuppression. And when you have a transplant patient come to ED immediately post-transplant and the kidney is not working, these are the most obvious things you should think about. Is the kidney obstructed? Is the blood supply good? Is patient dehydrated? And rejection is quite rare in this era because the medications have become so powerful, but drug toxicity is pretty common. Delayed graft function, especially of post-living transplant, is almost unheard of. We mostly do living transplants here. But if you do more DCD and DBDs and extended criteria kidneys, you are more likely to run. So I just got a small side note. I trained obviously in St. Louis. Charles Lindbergh, who, as you know, was the first aviator to travel from America to Europe. Charles Lindbergh was a Nazi, as you know, he was a Nazi. He and Alexis Carrel were the first people, because Nazis want to live forever. Most fascists do. And they were talking about organ perfusion, and they first built a prototype about how to perfuse organs so transplantation can occur. And Alexis Carrel actually won the Nobel Prize, one of the first surgeons to win the Nobel Prize for this. You may have heard this news recently where Bob Montgomery transplanted a genetically modified pig kidney to a cadaver. But this is not new, actually. Thomas Starzel, who's our great-grandfather for transplantation, did this in the 1960s. This is still far, far away. I mean, 10 to 15 years away, probably. And till then, we are still stuck with doing living donors and deceased donors transplants. So what are the medical complications post-transplantation? I think so electrolyte imbalance is common. Diabetes develops post-transplant because the medication which we use predispose you to develop diabetes. Rejection, acute rejection is less common, but chronic rejection is still common. Now in the West, chronic rejection is the fourth most common reason for ending up on dialysis, because the transplant program has become, pool is so huge now. So I will just briefly talk about these things. So mortality post-transplantation in diabetic is still cardiovascular. Okay? So diabetic transplants still die of cardiovascular disease. But in non-diabetic, in the West, 70% of those are non-diabetic recipients. Here is probably 50%, is infectious. So opportunistic infection or just a plain UTI can kill these people. Hypertension in a transplant recipient is very common, both from the native kidneys, which still produce a lot of renin. Many of these patients are obese. They suffer from sleep apnea. Sleep apnea is a huge problem in end-stage dialysis, end-stage renal disease. And uncontrolled renal bone disease can also cause hypertension. Medications. Some of our medications, unfortunately, increase blood pressure, cyclosporine, tacrolimus, and prednisolone. And that also, unfortunately, contributes to blood pressure in a transplant patient. Medication of choice, we like calcium channel blockers in the first year post-transplant, but the non-dihydropyridines, because they don't interact with CNIs. So the go-to medication for the first year post-transplant is a calcium channel blocker, followed by ACE-ARBs when the kidney function has stabilized 3 months post-transplant. As you know, the post-transplant, we're just monitoring the creatinine, and the creatinine can fluctuate based on the volume status. We don't like to use ACE-ARBs for 3 months, but sometimes they are used early, especially if there's proteinuria going on. Anemia post-transplantation is pretty common, not just because of the excessive lab draws, but because iron deficiency is common after transplantation. And ACE and ARBs, as you know, cause anemia. And sirolimus, which is not a favorite drug of mine, can also cause anemia. And one of the famous Brennisms is, if you care a damn, give a gram. So if you have a transplant patient with anemia, we just give 1 gram of iron. Hyperkalemia post-transplantation, it's again common, largely medication-induced, because the CNIs can cause hyperkalemia. We give bacterium prophylaxis, that causes hyperkalemia. Many of these patients are beta blockers because they have underlying cardiac disease, that can cause hyperkalemia. And so the treatment is usually giving a small dose of diuretics and getting rid of the fluid. We can't use things like fluorocortisone because most of our patients are already fluid overloaded. Hypercalcemia post-transplantation is pretty common because the renal parathyroid glands take 3 to 5 years to involute, that is if they don't have adenoma. So you will find hypercalcemia is most common, which is associated usually with hypophosphatemia, and that can be sometimes very severe and requires phosphate infusions. But usually diet alone is sufficient, because pre-transplant we've been asking them to not eat any dairy, not eat any animal protein, and they're still used to that diet. So usually diet change is required, and giving phosphate medications. Transplant diabetes is a very common problem. Largely, we kind of make it worse by giving a lot of steroids, especially when you're worried. We give a stress dose steroids, or we give 500 milligrams of methylprednisolone when we are worried the creatinine's gone up. So medications, especially the tacrolimus medications, we know causes diabetes. So we're trying to run the tacrolimus levels low will help, because tacrolimus is islet cell toxic. Sirolimus, other medications which was in a vogue a few years ago but no longer, can also cause diabetes. So speaking to if you're a diabetologist, speaking to the transplant physician, try and find a combination of medication which helps reduce the glycemic excursions will be helpful. Cholesterol, statins are used, encouraged in post-transplantation. Pravastatin has the least drug-drug interactions, but atorvastatin is pretty safe. Avoid fibrates. And it is shown to reduce some cardiovascular mortality in this review article. There's transplant-specific problems. If you have, then obviously you need to contact a transplant physician if the creatinine has gone up, especially from the baseline. Probably not the area. So work closely with the transplant nephrologists. So there are other long-term complications of transplantation. Malignancy is one, skin disease is one. Infection is the most common. Based on the time duration from the transplant, there are certain infections which are more common. Within first 6 months, something like CMV and BK nephropathy is common, but 6 months to 12 months, other donor-derived infections. Donor-derived infections are less common, but other infections are more common, like PCP or other viruses, based on how much immunosuppression you have received immediately post-transplant. Vaccination, avoid live attenuated vaccines, but every other vaccine is encouraged, and maybe you need repeat doses based on the antibody levels. Unfortunately, osteoporosis is very common, especially if they've been on dialysis for a very long time, and if you have used steroids both for the native disease and post-transplantation. Denosumab is a medication now being used, but unfortunately causes hypocalcemia. So renal bone disease is unfortunately still a major problem post-transplantation. In this part of the world, especially someone like me who has no hair, we have to use a sunscreen or cover our head. These patients are at risk of developing cancers, skin cancer, so we advise them to go and see a dermatologist once a year. You'll find that even if the transplant stop working, we physicians give them 5 milligrams of steroid, especially if they're for retransplant. So don't try and stop them, because even that non-functioning kidney can mount immune response if we suddenly stop immunosuppression. Sometimes if we stop the immunosuppression and the kidney becomes very painful, swollen, starts bleeding. So before starting the immunosuppression, please called the transplant nephrologist. Many medications interact with our transplant medication, so please check with the clinical pharmacist, especially if you're using antibiotics, if these are safe. And we do a frequent examination for following, work closely with your transplant nephrologist. And this polypharmacy prophylaxis is needed for graft prolongation. Hence, all these medications are important. So please speak to your transplant nephrologist before having to change these medications. It takes a village to make transplant possible, and everyone should be an equal stakeholder. And unfortunately, we've not had many people here, but gradually it's going to change. But unless everyone feels we are part of that program, the program will never grow. This is a meeting which I had organized 3 years ago. Got all the stakeholders from the region to look at various challenges why transplant is not growing. But hopefully we can all work together going forward. And I'm fortunate now to work in SSMC, which is going to be the Destination Medical Center. This is my email. Please get in touch. I've got many innovative projects going on, which have full support from the forward-thinking leadership of SSMC. And we hope to work together. There are many challenges to be solved. 1/10 of the world's humanity has kidney disease. And kidney disease is very expensive to manage. We are lucky we are in a country where the leadership of the country is benevolent and is paying for renal care for everyone. But I come from India, where 100 million people have kidney disease. This model of care needs to be disrupted, and new models of care need to be developed. I'm thankful that EOE government has funding one of my projects with Ericsson, and I look forward to collaborating with you more. Thank you.
Thank you, Dr. Anwar. Very happy that you brought the kidney issue, the pig kidney. I have a question for that since yesterday, and I'm glad that you brought it, but we'll have the question at the end. The next